I'm going to be discussing the electrical conduction throughout the heart and the different nodes. So to start off, keep in mind that the electrical nodes are responsible for conducting electrical impulses throughout the heart muscles so it can elicit an electrical response. And let's keep in mind one of the most important electrolytes that we discuss is potassium. And the whole purpose of potassium being in its normal level is because it aids in the conduction, in the proper conduction of the electrical rhythm. So always keep in mind that your potassium is 3.5 to 5.0, okay? And also make sure that you guys remember that your calcium is between 8.5 to 10.8, okay? Some books may give you slight variations with the calcium, but this is roughly around the level of your calcium levels. Now, let's discuss some basic terminology of the locations and what we have here. So to start off, we all know that the pacemaker is known as the SA node, okay, the sinoatrial node. And this SA node elicits a conduction towards the other atrium that we know as the intraatrial node. I'm not going to write that one down, it's not as important. However, just know that that's how the left atrium gets its electrical activity. The SA node conducts its electrical activity towards another node that helps relay that impulse to the lower segment of the heart, and that node right there we know as the atrioventricular node, or the AV node. Now, the AV node is really important because the AV node provides a pause, okay? It provides a pause when it comes to the electrical conduction, and that pause is responsible for what we know as the PR interval, okay? After the electricity goes down to the AV node, it passes through a collection of fibers that we know as the bundle of His, okay? The bundle of His. Then the electrical conduction continues downward towards the ventricles, and it passes through what we call the left and right bundle branches. So these two lines in here, I'm just gonna put a little arrow right there, and the left and right bundle branches. Okay, and that allows the electrical conduction to make its way down towards the ventricles to the myocardial fibers and muscles so it can elicit a contraction. And then it passes in through the Purkinje fibers that are embedded deeper inside the myocardium. And these little fibers that you guys see here are known as, again, the Purkinje fibers. It's important to note that you have to memorize these nodes and the sequence in how they travel. Keep in mind that the SA node sends a signal to the intraatrial node, to the SA node. The SA node creates a pause that's evidenced by the PR interval, and then it continues down to the bundle of His, left and right bundle branches, and then the Purkinje fibers. And when this is conducting normally, folks, it should elicit what we call normal sinus rhythm, which should look something along the lines of this. You have a P, QRS, and a T wave. Keep in mind that the first P wave, this one right here, this one represents the atria, and it represents what we call atrial depolarization. Okay, and then we have the Q, the R, and the S, and these QRS, those represent the ventricles. Now the ventricles are a lot larger. They pack a much greater electrical voltage. So the complex on the EKG is going to be a lot bigger. I need you guys to understand that because I'm going to be going over how to distinguish the basic different rhythms that we have, and it's based on the premise that you understand that the ventricles provide a much larger electrical conduction than do the atrias. So the QRS represents the ventricles, and so it represents the what we call ventricular depolarization. And keep in mind, guys, depolarization means action, okay? It's the D, okay? It's all the action. So D is the firing off of the electrical impulses. It represents what would be the physical contraction. And so ventricular depolarization is your QRS. And then we have the T wave. The T wave represents the ventricles as well. However, now it represents recharging, or what we call repolarization. Okay, so let's go back to these basic elements that we just discussed. In the heart, you have the electrical conduction system. You have the SA node, which is known as the pacemaker of the heart. Okay, and if the SA node is conducting its electrical impulses normally, then that means that your resting heart rate should be anywhere from 60 to 100 beats per minute. Okay, the electrical conduction goes from the SA node down to the AV node. Now, the AV node also has an ability to create or sustain heart rhythm in case the SA node fails. But keep in mind that its rhythm is limited to 40 to 60 beats per minute. Okay. Now, the AV node, the atrioventricular node, because it's between the atrias and the ventricles, right? The AV node creates a pause, and this is correlated with the PR interval that I'm going to be discussing right now, but essentially, it's found right here, that little flat line between the P and the Q wave. The electrical impulse then makes its way down, passing the bundle of His, through the left and right bundle branches, and then down into the Purkinje fibers, which it generates an electrical impulse, which hopefully will allow for contraction, and that's how the electrical rhythm continues throughout the heart, and that's how we get our lub-dub, our contraction, and eventually cardiac output. Now, let me discuss some basic elements that deal with normal and abnormal rhythms. I want you guys to be able to distinguish some basic rhythms, whether they're atrial or whether they're ventricular issues. Now, we discussed normal sinus rhythm. Normal sinus rhythm, generally speaking, is 60 to 100 beats per minute. It contains a P wave. It's followed by a QRS, and then it ends with a T wave. All your complexes or all your complexes should be equally distanced from one another. For instance, P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. Generally speaking, they're sort of more or less equally separated from one another. That's how you understand that this is normal sinus rhythm. They all have a P wave, they all have a Q, an R, an S, and they all have a T wave. And keep in mind that your PR interval should be short. Let's discuss some basic values for these different rhythms. It's important for you guys to understand that the PR interval should be anywhere between 0.12 to 0.20 seconds. Okay? For those of you that don't know what I'm talking about in regards to the 0.12, when you guys look at the graph sheet where the EKG readings are printed out from, you have a graph that has large boxes and smaller boxes within. Okay? Keep in mind that your small box, okay, the small box, that one represents 0.04 seconds. And then you're gonna have the larger box. And of course, these are not up to scale, but the larger box represents 0.20 seconds. So when you guys are reading the distance between the PR interval or the QRS, you're going to be utilizing the background graph sheet to estimate your time duration that each of these complexes or portion of the complex should be aligned with. So your PR interval should always be between 0.12 seconds and up to 0.20 seconds, and then your QRS should be anywhere from 0.08 to 0.12 seconds. Keep in mind that different books give you slight variation in the values. This particular value is obtained from the ATI book, I believe the 9th edition. So keep in mind that you guys review your policy protocol and your school and what books your school is basing its laboratory findings by. And usually it's ATI books, especially nowadays. ATI is the creme de la creme when it comes to these values. So you have to memorize these values, but for the sake of understanding rhythms, just keep these in the back burner, and we'll discuss a little bit more on how to be able to distinguish your atrial from ventricular issues. Generally speaking, when you have an atrial issue, the atrials are smaller, the muscles are not as thick, so the electrical conduction that it's carrying out or pushing out is relatively small in comparison to your ventricles. The ventricles are a lot larger, the The ventricles are responsible for pumping blood throughout the system, whether it be the right to the lungs or whether it's the left throughout the whole body. So keep in mind that the electrical charge is always going to be greater when it's outputted by the ventricles, by your bundle of His, by your left and right ventricle, left and right bundle branches, your Purkinje fibers. Those, the output, the electrical output that those carry out is a lot bigger, and it's evidenced by this basic PQRST complex. Your P wave is smaller than your QRS, and look, even the recharging, the repolarization of the T wave is still bigger than the depolarization, the action, the firing off of the P wave. And that's important for you guys to know. Let's discuss some rhythms now, applying this basic concept that I'm trying to give out right now. So when we're talking about abnormal rhythms, we have to always compare it to our normal sinus rhythm. You guys have to know what the normal sinus rhythm is, and I'm gonna place it one more time up here. Normal sinus rhythm, okay? And that's gonna be your P, Q, R, S, T. It follows the train of thought that I'm discussing, that your P wave is smaller than the rest of them, that you have your Q, your R, your S, and then your T wave. Keep in mind that a normal P wave is followed by a QRS. And a normal QRS is after a normal P wave. And at the end it will have your T wave. But what if you have this type of rhythm? Okay. The question is, do we see a definitive P wave? What's wrong with this particular complex? The thing that's missing is the definitive P wave. We don't have one. Because the P wave is representing the atrial electrical conduction, and the atrial electrical conduction is relatively smaller than the ventricular one, well, when there's an atrial issue, it's only going to be observed in the location where the P wave is supposed to be located. Notice that the QRS and the T wave are not affected by this. So that's how you know that this is an atrial issue. Okay? Next thing you have to know is memorize the abnormal quivering. That's going to be manifested in fibrillation. Okay? When you have atrial fibrillation, keep in mind that the atrias are quivering. The electrical conduction is not being conducted adequately, and instead of it being elicited enough for the contraction to occur, the atrias are just quivering like jello. And that's what elicits this fibrillation, this abnormal, chaotic, very abnormal rhythm in the where the P wave is supposed to be. But keep in mind that whatever's going on with the atrium is not affecting your QRS and your T wave, because the issue at the P wave, the issue at the atrias, the electrical impulse is not great enough to affect anything that happens in the ventricles or the QRS and T wave. We have another one. Let's say you have something like this. Okay, using the same logic, what do we see? What do we not see? Well, we see the QRS and T wave, but what we don't see is a definitive P wave. So we know for a fact that this right here is an atrial issue. Okay, and based on memorization, what the textbook says, when it looks like a seesaw, this is known as atrial flutter. Okay, when I think of atrial flutter, I always think about a fish flopping out of water, just flopping around. That's kind of what the atrials are doing in this particular scenario. They're not contracting adequately, they're not pushing the blood all the way through, but they're just flopping around, so atrial flutter. Keep in mind the same logic. Notice that you don't see the P wave, you don't see the definitive P wave, but you see the seesaw action. But it does not do anything to your Q, to your R, to your S, or to your T. Because whenever you have an atrial issue, it does not affect, it does not spill into the ventricular area, because the conduction of the ventricles are far too great to be bothered by any abnormalities in the atrials, where the P wave should be. Let's look at the next abnormal rhythm. What if you have something like this? Now this is something new. Notice that we have to go back to normal sinus rhythm. This is what it's supposed to look like. Do we see a P wave? No. Do we see what a QRS is supposed to look like? No. And do we see a T wave? No. But we see something different. We don't see a P wave, we don't see a QRS, we don't see a T wave. What you have to ask yourself is this an atrial or is this a ventricular issue? The train of thought is that when you have an atrial issue, like in these two problems, it does not affect the ventricles. However, the ventricles are so highly electrically charged that when there's some abnormal rhythm going through them, it will mask all other rhythms, including its very own normal QRS. So in this case, we look at this rhythm that looks abnormal. It looks a little bit chaotic. However, it is rhythmatic. It kind of looks like an M, right? Well, this is what happens when you eat too much McDonald's, okay? This is known as ventricular tachycardia, okay? We know it's a ventricular issue because the only part of the heart that's strong enough with its electrical impulse to mask all other rhythms is the ventricles. When there's something wrong with the ventricles, you're not going to see what the atrias are doing. When there's something wrong with the ventricles, you're not going to notice the normal QRS because there's something wrong with them. Generally speaking, VTAC is greater than 100 beats per minute, okay? And it looks like McDonald's arches. Keep in mind that the only part of the heart that's strong enough with its electrical conduction to mask other issues is going to be the ventricular electrical impulse, the ventricles. Let's look at the next one. Okay. Okay. When we look at this rhythm, do we see a definitive P wave? No, because the P wave has a QRS following it, and we don't see that pattern there. Do we have a QRS? No, the QRS is relatively narrow. And it's usually preceded by a P wave and followed by a T wave. Do we see that there? No. Do we see a T wave, usually preceded by a QRS? No. So again, the only part of the heart that's electrical conduction is strong enough to mask all other rhythms when it's abnormal is the ventricles. So we know for a fact that this right here is a ventricular issue. And this, because it's chaotic, it's got no rhythmatic pattern, it does not look like McDonald's arches. We know it's the ventricles, so we know it's ventricular, okay? But in this case, it's ventricular fibrillation. It's important for us to know that the ventricles are the parts of the heart that push blood and convey them to either the lungs for gas exchange or through the cephalic region or the entire system for perfusion, for systemic perfusion. Because of that, the first thing you do with any of these abnormal rhythms, you always assess the patient's pulse. Is it pulseless or do they have a pulse? Generally speaking, your ventricular fibrillation, you're not going to have a pulse. And if that's the case, then you need to start CPR. Okay? You need to start CPR until you can bring an AED and do defibrillation. Keep in mind that defibrillation is using high-powered joules for the electrical shock. We're talking about 250 to 360 joules. That's a lot of power, a lot of electrical activity.